Hello and good evening. Good evening, good evening, good evening. And welcome to the GUBA Diaspora Conversations. Tonight, we will be speaking about a topic that's not only very close to many of our hearts, but also very close to my heart. And it's about women's health. Women's health in general, women's health when it comes to pregnancy, women's health when it comes to natal care. We have got our professionals, our panelists of medical professionals on hand to answer your questions. We are going to have an open discussion and we are going to delve into some of the cultural, the traditional, the issues with our ethnicity and how that affects us ladies, us women, and our health needs. And these are topics that we need to have discussions on. We need to look at how we can deal and how we can support some of the issues as women that we face, okay, based on our ethnicity, okay, our traditions in Africa, our culture, our family community, how we tackle these issues, how we discuss these issues, how we support each other in dealing with some of these issues. I'm not a medical professional, but I do have the medical professionals that will be joining me to discuss openly. But again, a warm welcome to you all to tonight's session. So for those of you that do not know, my name is Jennifer Djan-Krofa. I am the head of Diaspora engagement and partnerships for the GUBA Diaspora Network. And the GUBA Diaspora Network is a project or initiative under the GUBA Enterprise brand that supports the diasporan community. If you want to connect, transition, do business, invest in Ghana, whatever it may be that you need to do or that you want to do, we are here to help and facilitate your needs. And we understand that lots of people have that desire to connect. Lots of people would like to do stuff in Ghana or Africa as a whole, but it's all about understanding the roots, the how you go about getting things done in Ghana. It's a different terrain, especially if you've lived outside the country for many years. And it's always important to have that community and that support in order to help you facilitate your needs. So what we have is a membership community of diasporans from all over the world that reach out to us for one reason or the other to assist them in their needs. And today's session was actually brought about by one of our members. And this lady is a medical doctor, highly experienced in the UK as a medical doctor of Ghanaian background. And she's very passionate about gynecology, very passionate about women's health, very passionate about supporting the community. And when we talk about supporting a community, it's not just in UK, but actually in Africa, in Ghana as well. And I'm going to introduce her in a moment. She's going to talk a bit more about who she is, what she does, and why she's doing what she's doing. But as an overview, when we look at the theme of women's health, why are we discussing women's health? Why is there a need to talk about it? Why is there a need to come together and understand some of the issues that people face? Women's health is a challenge in different contexts. When it comes to the family, when it comes to culture, when it comes to traditions. And we as women, we also need to look after our health. And questions might arise like, are we doing the right thing? When we're weighing up culture and science or, traditions, what the family says and what the medics say, what direction are we going in, and are we doing the right thing? So all of these are questions and topical issues that we are going to discuss today. And as I mentioned, we're going to hear from the professionals that will give you a bit more of an overview of some of the issues that they face, some of the teachings that are important for women to understand. And not only that, but we're looking at how we can actually look after our health. So thank you once again for joining us, wherever you're joining us from. Okay, so we've got Mindset of Yahweh. Oh, lovely. So we've got you are viewing us from New York. Okay, welcome, and thank you for joining us from New York. We do have this showing on Facebook, on our GUBA Foundation page, as well as on YouTube. For those of you that would like to share the link, do invite your friends, your family, women in your community, your associations, your organizations to be part of this conversation, because it really is a conversation that needs to be had. Okay, so without further ado, I'm going to invite Dr. Jacqueline. I'm gonna bring her on the screen. Okay, oh, if you just bear with me. Hi,
Hello.
Dr.
Hi.
Jacqueline.
Hello, Jennifer. Hi, how are you? Can you hear me? I think we've got technical issue. Hello? Hello?
Hi, hello. Apologies, I believe that there was a technical issue, but we're back. Hi, Dr. Jacqueline, I'm back. I didn't abandon you. Apologies.
Hello, Jennifer.
Okay, excellent.
Okay,
Please go ahead and introduce yourself and who you are and, what tonight's session's about.
great. Jennifer, first of all, thank you so much for arranging and organizing this. I'd like to thank the GUBA Foundation. I think GUBA has really united and allowed so much of the diasporans to come back together, and it's really wonderful. So my name is Jacqueline Bamfo. I am a consultant obstetrician and fetal medicine subspecialist. I'm based in the United Kingdom. I practice in the NHS. My NHS practice is Luton and Dunstable Hospital. I was born in Ghana and moved to the UK when I was 6. I grew up in London and went to medical school in London. I went to Imperial College School of Medicine. And then after my postgraduate training, I essentially rotated around the London hospitals. I undertook a 3-year research fellowship at Harris Birthright Research Centre for Fetal Medicine, King's College Hospital, under Professor Nicolaides, who is what we call the father of fetal medicine. This was an amazing opportunity, and it was an amazing experience to learn about fetal medicine. I conducted my research on preeclampsia, which is a subject that's really close to my heart, and also fetal growth restriction. I went on to take further subspecialty training in St. Mary's, Manchester. And in my current role, I am the lead for fetal medicine services within my trust. I also undertake a lot of teaching and training. I'm the director of a private scanning clinic and also a new community interest social enterprise called Interwoven, which has a focus on maternal health and also child health, in particular children with neurodevelopmental problems such as autism. I am Ghanaian. Ghana is my home. Ghana is my birthplace. And it's really for the love of Ghana and also the love of my mother, really, that I want to keep my roots in Ghana and want to work to develop maternal health services within Ghana. In terms of tradition, I am an Akan. So, it's just a wonderful opportunity to do some work in Ghana and network with other health professionals in Ghana.
Excellent. Thank you. Thank you very much. And I think as you were speaking, your passion definitely came out in terms of, your whys, what is leading you, what's keeping you going, and why you want to not only connect with Ghana, but also support the provision and support your professional field in Ghana. I mean, possibly a question for me in general, when we talk about pregnancy, when we talk about gynecology, can you just give, for those of us that are not in the medical field, can you just give us an overview as to what your role involves? What is gynecology? What does it mean?
Okay, so most of us, so the way it works with medical practitioners is that you do your core medical training, you do your medical school training, you graduate as a doctor, and then you do your first few years trying different specialties until you land on the one that you think, yeah, this is the one for me. Obstetrics and gynecology it's one specialty, but it's 2 halves. Obstetrics, which is the care of the pregnant woman, from the moment of maybe the early conception until she delivers, and then up to 6 weeks after birth, which is the postnatal period. Anything concerning the pregnant women, the medical conditions they have, the labor and the delivery, and looking after the baby, scanning the baby, assessing the development of the baby. Gynecology focuses on women of childbearing age and also women all the way through their reproductive life cycles until after the menopause and then beyond. So when their cycles first start, when they have their children, and any sort of problems they may have after that, as they go through their 30s, their 40s, their 50s, and then the menopause, the menopausal symptoms, and then after postmenopausal, where if there are any issues that arise again, the gynecologist will look after them. There are some of us that do both, obstetrics and gynecology. I'm a pure obstetrician, so I'm a mummy baby doctor. And others will just say that, no, I'm just going to do gynecology and I'm going to leave all the baby stuff to you. So they are different, but then in a way we work together because we're looking after the same women. I can't hear you.
Sorry, there, I've got my microphone on pause. So for me, women's health is an important issue, and it's an important issue in today's discussion because it not only just talks about women's health in general, but also the cultural aspect of it, the impact of who we are as African people. So that again comes with its own queries with our ethnicity, our cultural practices, whether or not, we've kind of been brought up to do certain things. Is that the right way medically that we should do it, or are we harming ourselves in doing so? And, again, along with traditions, how our traditions impact the way we do things. I mean, of course, over the years, we've kind of acquired more knowledge, we've kind of acquired more understanding of certain things, but does it still play a big part? And if that part is played, what sort of impact do we have? So I guess that's part of our open discussion in today's session. Thank you ever so much for that. I'm also going to now introduce, just want to check. I'm also now going to bring on one of our doctors, okay, another doctor, and this is Dr. Theodora Pepera, who is based in Ghana. Apologies if I pronounce your name wrong. Based in Ghana, and she will speak about her role and what she does. Thank you. Hi, good evening, Dr. Theodora.
Good evening. Hi, hope you can all hear me. Hi.
Yes.
Okay.
If you'd like to introduce yourself, what you do, your role, and what you do in Ghana.
Okay. Thank you very much for inviting me to join this talk. And I think GUBA stands for basically bringing Ghanaian Union together and helping Africa. I was born in Ghana at Ridge Hospital, and actually went all the way through and schooled in Achimota School for a bit until a snake bit me and the school grounds, and my mum whisked me off to the UK, where I went and continued and went on into medical school. And like Dr. Bamfo, I went to one of the London medical schools, the Royal Free, and then after that bounced around mainly in London teaching hospitals, eventually becoming a consultant at Guy's and St. Thomas's. I did manage to drop obstetrics for a while, handing it over to people like Dr. Bamfo, where I specialized more in gynecology and particularly in the prevention of female cancers, particularly cervical cancer. That's my main area of interest, where I train people a lot. So back in 2013, having been a consultant for a few years in the NHS, I decided to return to Ghana. And initially I was going to set up a private clinic, but I thought, well, that's too easy. I thought I'd focus more on training, because that's why I could see a greater need, because I could see some disparities, as you say, in attitudes towards the way women particularly were being treated, from how I'd seen in the UK to what I'd seen in Ghana. And so set about really delving into that and really going a lot into the counseling, how we counsel women and how we have to take time with them and be non-judgmental. And I think, whatever we do in obstetrics or gynae or in any aspects of healthcare, we have to be really mindful of that. So that was really my passion. And I started returning, I'd say it's almost 10 years now. It hasn't been easy, quite a number of obstacles. I certainly have some thoughts about how the path could be made easier, because there are a number of people who do want to come back. But I would say that one isn't particularly welcomed back, and you have to be very determined if you want to come back, but it's well worth it, and there's really no place like home, really.
Yeah, definitely. I mean, I think kudos to you for actually taking that bold step and deciding to come back and support Ghana with your specialism and, you know, helping the community. I think you've touched on one or two things that do, if you want to call it, hinder or hold us back in terms of, you know, having that experience in UK in a completely different health setting, health system, and coming to Ghana and then also trying to impart your knowledge, your experience within that health context. There are challenges on both sides when we talk about the healthcare and the systems that we work with. But one of the things that I do want to maybe you know, tickle you a bit more on is the how you were embraced, how you were welcomed with your knowledge from a different healthcare system, and you know, possibly your colleagues or the hospitals or the health facilities. How did they engage with you when you initially started, and what that was like for you?
Well, I'll be honest with you, I wasn't embraced.
Okay.
It was a challenge. There seems to be sometimes, and I'm not going to generalize, so sometimes perhaps a level of suspicion. What are you coming to do? Are you coming to tell us to do things in a different way? Because I came back really wanting to get involved and help. And I found a number of doors being closed at various medical institutions. But I was very determined, and I'd been warned that there would be this attitude, right from even trying to register with the Ghana Medical Dental Council. I would say at that time, this is in the late 90s, they were bordering on obstructive. But I was determined. I've chiseled through, and I think now we have a good understanding. And I've since run training programs at Ridge Hospital and Kolibu Hospital, Polyclinic Reproductive Health. I'm running a program there next week. So it's not easy, but I think it's well worth persevering and breaking down those barriers. And then when they see that you actually just want to actually really just help and improve things, then some of the shutters start coming down. But open arms, definitely not.
So I mean, I guess from what you're saying is that there was a barrier for you to kind of integrate back into the society, the profession, and you know, you were met with a bit of hesitation from your peers, if you want to call it that. But I think what you have said is that that was the early 90s or the 90s when you first
Well,
came
it
back.
persists. That was the late 90s, and it's taken me years to get through to the point where I am being invited to come and give talks and so on. So I think it's something that we shouldn't think is in the past, but I think it's something, what I'm saying is it's something that we can overcome. And I think with more transparency and perhaps with more people returning, you know, and perhaps with better education or knowledge, people should learn to be not threatened, but more welcoming of somebody returning. It's all for the good of all of us, really, because I learn a lot when I go and run courses. I learn a lot from the people that I teach, an awful lot. So that knowledge exchange is definitely there, and it's a good potential. And I think that's how it needs to be viewed. I think people coming from outside shouldn't necessarily think that they're coming to do things bigger and better. That's definitely not the attitude. And I sometimes see that in some colleagues who are returning, you know, wanting to give themselves a pat on the back, coming to help Africa, and it makes me cringe. And so you can sometimes see why there's that level of suspicion. So I think there needs to be more transparency on both sides, and perhaps organizations that help make that connection between people so that things can run more smoothly.
Yeah, definitely. I mean, Dr. Jacqueline, what would you also say in addition to that?
Ditto. This is where I am. I've submitted my application, and at the moment going through some challenges, should I say. So let's hope that at some point there will be a window of opportunity and I will be able to get my registration. Yeah.
Yeah. I mean, I think that definitely is a conversation, because you know, it's about working together. It's not about teaching, you know, belittling or undermining practices. And some of these, you know, some certain traditional practices have been there for years. It's not about undermining and anyone feeling better or thinking that they're better, but it's about working together for the betterment of the entire, you know, system. And of course, there are things that can be learned on both sides. So I think that is a voice that needs to be.
One thing I'd like to say also is that we just look at business as a model and the value of business networking. You know, the internet has revolutionized, you know, it's just changed our lives. We're able to do this now across different, you know, cities, towns, continents, and we can work together collaboratively. We all work in our different ways in different countries, and we learn things. So we have to bring that together, that knowledge together, so that we can share and we can improve our societies. So we really need to embrace, we need to welcome, we need to network, we need to get good practices in order to raise our standards. And also, there's so much value for us coming there. You know, when I came to Ghana in January and I visited Kolobu, and I visited International Maritime Hospital and University of Ghana Medical Center. And the thing that I took away back with me was the teamwork and the optimism and the, you know, a lot of the stuff of really happy. And then I came back here and it was like strikes. And it was, you know, so it works both ways. You know, I being there has enriched my life and enriched my experience of medicine and my attitude. So I'm now moving forward thinking, you know what, that's not such a bad thing. You know, whatever the situation is, I shouldn't be so grumbly. I should, you know, look on the positive side or make something out of whatever situation. So I think it's good. It's good both ways.
Yeah, brilliant. Thank you ever so much. I'm now going to invite Dr. Betty, who will also share a bit about what she does, who she is, and the impact that she is bringing to the profession as well. Dr. Betty, good evening. How are you, and welcome? Oh, we can't hear you. I think you're on mute.
Hi, Jennifer. You're right.
Hi.
I was.
Okay.
How are you?
How are you?
I'm doing well. And greetings to you. Greetings to your viewers and listeners. I'm Betty Anane-Fenin, an obstetrician-gynaecologist with subspecialty in maternal fetal medicine. I've lived almost my whole life in Ghana. I trained in Ghana, and it was only the subspecialty I had to go do it in South Africa because it wasn't running in Ghana at the time. Since I've been back, I've been involved with the training of the fellows in the Ghana College who also want to be maternal fetal medicine specialists. Actually, we started off with just two of us. Both of us trained in South Africa. The first one is a male. He came in the early days of 2021, and I came in the latter part. So we have been working together to see that the college actually gets a firm grounding on the subspecialty training. And I'm glad to say Jackie also came on board, and she has been well embraced, and I hope she comes more often. So I work in the Cape Coast Teaching Hospital and in the Central Region. I have been able to set up a small unit for my the maternal fetal medicine unit. I was quite fortunate to have the support of my central management and my department. They have really spurred me on and given me all I need, all the resources, well, almost all the resources I need to work as a subspecialist. It's a fairly new area in Ghana. So, I mean, explaining to people what your role is a task. And my interest, as Jackie said, is purely obstetrics. And that is why we've led the gynecology aspect to Dr. Pepera and the rest. So my interest also lies in preeclampsia, hypertension in pregnancy, and diabetes as well. So I have been able to. You got me now?
No, it's fine. Just before you continue, I'm not a medical practitioner, and I believe many of our viewers are not medical practitioners. So if you could just explain obstetrics and preeclampsia and what they actually mean, so that they can also engage.
Good. So the obstetrics aspect is what Dr. Bamfo earlier explained. That is taking care of the pregnancy journey up until the 6th week post-delivery. So when we talk about the preeclampsia, we are basically talking about a complicated kind of hypertension that develops in pregnancy, and it actually affects almost every organ in the mother. The liver, the kidney, the heart, the brain, all of those can be affected. And the baby, the unborn baby, can also suffer in utero before it even comes out. It's actually a leading cause of death in sub-Saharan Africa. For a long time now, obstetric hemorrhage has been the first and preeclampsia the second. At a point in time, it appeared preeclampsia was overtaking obstetric hemorrhage in a lot of our tertiary institutions. So it's actually quite a topic that we need to discuss. Is actually something we need to curb. And the good thing is that we have prevention for preeclampsia. We identify high-risk women. If you don't have the sophisticated model that the fetal medicine specialists use, we can use the clinical risk factors like the age of the mother, having chronic medical conditions like hypertension, kidney disease, previous preeclampsia, having a multiple gestation or a twin pregnancy, all those risk factors clinically we can use to identify them. And the role of aspirin and calcium has also been well emphasized in literature and even clinically or practically to reduce the rate of preeclampsia. So that's what I'll say about it.
That's fine. Thank you. We have a question. It's just a quick question, and I think it's something that you touched on as you were introducing, that the leading cause of death is preeclampsia, or was preeclampsia. Can you expand a bit more on that? Why, and is it particular in the African continent or of women of a particular age? If you could explain a bit more on that.
So actually, the Black race has been, or the people of African descent, is a risk factor to the development of preeclampsia. And the way it happens, if you are a regular antenatal attendant with adequate knowledge on it, you may be detected early, and the complications, including death that may occur, could be averted. But you know, in our part of the world, we get to see the complicated ones because they are usually detected a little late. And in other parts of the world, it is quite, everybody's trying to prevent it, but it's not so widespread in Ghana currently, but the knowledge is traveling. So that is why more on our side with all the complications that comes with it. The obstetric hemorrhage actually is the leading cause, and preeclampsia is the second. But I was talking about some tertiary institutions in the country that at a point saw the preeclampsia or the hypertensive disorders of pregnancy becoming the #1 cause of death, probably associated with the neurological or brain complications, the kidney complications, the liver complications, all of that can arise from the condition. And you know, the resources we have also to tackle some of these critically ill patients are lacking in most of our centers. And I'm sure we'll delve a lot more into some of these problems we have in our health sector.
Okay, thank you ever so much. Finally, I would like to introduce Dr. Bright onto the panel, and Dr. Bright will also share about his role as a medical practitioner and how he supports women's health as well. Hi, good evening, Dr. Bright. How are you today?
Right. So, hi everyone.
Hi.
Yes, my name is Bright Gyampoh. I was born and bred fully in Ghana. So I started my life in Koforidua, which is in the eastern region. First 10 years of my life was there. I went to Madonna School and transitioned to Kumasi Prempeh College, made my way up to the School of Medical Science, KNUST, until 1992. Then I did 2 years of my house job and medical officer. I think that is how they explained it. Medical officer at 37 Military Hospital before I flew out to the United Kingdom. So I did my postgraduate training with the North London Deanery. So that is where I did all my rotations, and then eventually managed somehow to become a consultant in 2008. I have practiced literally all my consultant posts or jobs at the Luton and Dunstable Hospital. So that young girl over there called Jacqueline Bamfo is my workmate. My passion really is both obstetrics and gynecology. I'm being pushed out of obstetrics, but I am not giving up on obstetrics because it's an area that is really interesting. In terms of gynecology, meaning not dealing with pregnant women, my field of interest is minimal access surgery. So we do the keyhole surgeries, laparoscopy, hysteroscopy. So when it comes to gynecology, someone requiring removal of fibroids, not the huge ones, but removal of fibroids, polyps, anything that needs to be, endometriosis treatment, all those things are done primarily by keyhole surgery, and that is what I do. And I do that in addition to being an obstetrician as well. Now, in terms of obstetrics, I play a leading role in obstetric risk management. So, accountability, why things go wrong, we need to look into that. And that is my lead role at the Luton and Dunstable Hospital. In fact, I was a clinical director for about 5 years, and I just got fed up and tired and gave up and tried to do some more clinical work. Now, why Ghana? The answer to that is why not Ghana? That is where I was born and bred. I had all my training in Ghana, so why don't you give something back to Ghana? So unlike Theodora, I did not go as an individual. What I did was to set up with a couple of friends and family, set up a charity, because what I picked up from here was, all these causes of maternal death, major obstetric hemorrhage, so a woman who's had a baby and is bleeding heavily, eclampsia, maternal sepsis, infections. These are the main causes of maternal death. And it's not just Ghana, the whole world. Okay? Maternal collapse, obstructed labor, ectopic pregnancy, genital tract infections. These are things that kills our mothers and our sisters. But being part of the training team at Lieutenant Dan Stubble Hospital, I realized that the interventions that we do, we train and practice, these things can be done in Ghana. So why don't you take the same model, take it to Ghana and see how it helps, and see whether they will embrace it or not. So we set up a charity foundation called the Trio Bridge Foundation. Trio simply means Training for Improved Outcome. So TRIO, Training for Improved Outcome. And the bridge was, what we thought about was, how do we bridge the care in Europe and Ghana? So every year from 2018, we go as a group, 12, 14 Ghanaian professionals. We take our Obroni professionals with us, so midwives, nurses, we all go to Ghana. And what do? We train the doctors and midwives and nurses on teamwork management of obstetric emergencies, teamwork management of neonatal emergencies. So that is what we do. And we've been doing that since 2018 from various hospitals. The main hospitals that we've done this training in are Wenchi Hospital, Ankasi Hospital, 37 Military Hospital, University of Ghana Medical Center Limited, the brand new shining hospital. We've done all this training there. And then someone may ask, how are they embracing this kind of training? I think it's been brilliant. Our colleagues back home do extremely good job in some really, really difficult and challenging environment. Just amazing. The way they manage to innovate and do certain things is mind-boggling. But they need help. And that is where I think we can all help. As somebody said, we are not there to, change things and get people to do what we do here. No, that's not possible. A way of giving them a different approach. Yes, this is how you do things, yeah? But what about this? Have you thought about doing it this way? And that is what we do. So Trowbridge Foundation, we've been doing this, and it seems to be helping. It seems to be working. Did they embrace us? Yes. It wasn't difficult at all. And it wasn't difficult because, number one, I had practiced in Ghana, and I had practiced for only 2 years, 2 years in 37 Military Hospital. So I knew people there. I knew a few friends. So it was easier going back. And I was very popular in that hospital as well. Not in a bad way, but in a very good way. So it was easy going back. But also, more importantly, we introduced this concept to the Methodist Church when a few of their, in fact, 12 of their bishops came to this country in 2018 for a conference. So we met them and said, look, we want to help. Would you accept that we want to help? They said, yes, come, no problem. So that is where it made it easier, because this was from the top hierarchy of the Methodist Church. So if they say yes, then who are the others who say no? And the concept made sense. Besides, we were also going in there with a few gifts, a few donations, which, If somebody is coming to donate an ultrasound scan machine to your hospital, I don't think you will say no to it, would you? So this is what I did with my fellow colleagues to gradually worm our way back into the system in Ghana. And it is something that has come to stay, and I'm not going to give up. And I'm pulling more people to join us this time because we are coming on the 22nd of September for another round of training.
Excellent. Okay, excellent. And definitely we'll be there to engage you with that. Thank you ever so much, Dr. Bright. I can see numerous questions popping up on the screen. We've got people on Facebook, we've got people on YouTube, and people texting in and sharing a few questions here and there. But before we go into some of those questions, just want to ask okay, we women in the UK, we have specific screenings that are mandated by the government, by the laws, by the systems in place that we must have done. Okay, and I believe that those screenings are there for a reason, to kind of help avoid later complications and so forth. What kind of screening programs are in Ghana for women? So I guess that's an open question to anyone that would like to ask that answer.
Well, I think in terms of government mandated screening, I'm talking about mainly early cancer diagnosis in women, and perhaps the most preventable cancer is cervical cancer. And we have so many cervical cancers in Ghana, not because it's a different disease here, it's just that we're not detecting it in the 10 years that we have to detect it before it becomes cancer. And the UK only started making an impact on reducing their cervical cancer rates in 1987 when they introduced what's called the call recall system, where they don't mandate, but you are heavily invited to come for a pap smear from the age of 25. They will send you at least 3 letters. And eventually, if they're discharging you off the program, they even have to inform your GP to make sure they've even got your correct address. So huge efforts are made. And when that call recall system came in, only then did they see a big decline. So, I mean, other countries such as the US and Ireland, other places in Europe don't have these programs. Now, in Ghana, I see the potential for us to do that. And also the potential for it to be subsidized in some way, because it costs an awful lot to treat somebody who has cervical cancer, and prevention is far better. And now we even have the vaccine. But all these are being, they're kind of competing with other priorities in the country. So it is difficult. But then, having said that, even when the vaccine is available, you touched on the beginning myths and taboos. And I mean, goodness, when the COVID vaccine came in, they said it would turn you gay. So yeah, we do have a lot of things challenges to work against. And even in the UK, some women were saying the vaccine's going to make my daughter promiscuous and so on. But, the vaccine has been around for over a decade now, and the reduction in cervical cancer is enormous in countries that have introduced a vaccine. And then we say a big shout out to Rwanda. Rwanda has brought in a vaccination program, and they are doing it. So it's not just Africa can do it. We can. It's just that we need the drive. In terms of other things in women's health, again, this is not only women's health, but we do have this thing of, somebody falls ill or they have a condition, it's a witch in the village that has given it to them. And sometimes that's why they present very late. And as Dr. Bright said, it's amazing what the healthcare professionals in Ghana have to deal with, because they're dealing with people presenting very late with conditions that we see very early on in the UK before they even reach anywhere. So sometimes what they actually try and do to rescue these women is amazing. But a woman would rather go and see her pastor than see the doctor first. But then you need to ask why. Maybe because the pastor is nicer to her. Because again, I'm not going to generalize, but I've seen some fairly and heard some fairly shocking interactions that patients have had with their doctors, especially women who've been belittled or had suggestive comments made and or being judged. So the pastor will be all very nice to them and can charge them what they like and make them pay 1,000 cedis for some holy water, and they'll pay for that. They want to go somewhere where they are actually listened to and not judged. And where I work at the moment, I do have quite a waiting list, and I'm by no means at all the best gynecologist around, and I do a bit of antenatal as well. I used to. So I handed it over to people like Betty. I don't want to do antenatal stuff anymore, handing over to the younger ones. But what's my USP? My USP is I listen, I give them time, and I don't judge.
I think judgment is a big thing at times. Yeah,
it's a big thing, and I think we need to step away from it. They always want to know, are you married, and how many partners, and so on and so forth. And when I ran some training in Colposcopy a few years ago, they said, oh, well, cervical screening, we have to ask how many partners they have. And I said, well, why does that matter? They said, well, because if she has a lot of partners, she's high risk. I said, well, what if she has one partner and he has several partners? Then they went, oh, good point. I say, exactly. So there's no point trying to stigmatize the woman or the condition. The other thing I'll just mention is that apart from research, I'm also UK faculty for a number of organizations, International Organization for Ultrasound and Obs-Gynae called ISOG. So I've been on a few training programs with them to Ghana, and the International Federation for Colposcopy, which is where you go when you have an abnormal pap smear. And certainly when I was working with the ultrasound group a few years ago, I noticed that they were doing ultrasounds on women and then asking them when their last period was. And I said, well, how can you start taking a history from somebody whilst you're doing the scan? You should know before your scan what you're expecting to see. Has she missed a period or has she not? Does she have any menstrual problems? And what they told me was that, or they were told, it's not Ghana culture to talk to patients. So, well, that then affects your clinical knowledge, and it becomes a risk issue. It's unsafe to not speak to a patient before examining them. And and patients do say, if you ask too many questions, the doctor will tell you to take your notes and go. So it happens. I mean, I'm pleased. Of course, it's not a general thing, but it happens. And I just also want to touch on the fact that training is so important because, yes, I've got sort of over 20 years, 25 years experience in colposcopy, cervical cancer prevention. And I'm aware that some women who could be treated, who don't have cancer, but just have these precancerous changes, which are very easily treated by a 10-minute treatment to kind of burn the abnormal cells off, are being offered hysterectomies. And that this is just negligent, and it's a bit criminal. And I need to put it out there because it is happening. So one of the things that I run a number of training courses, and Dr. Efa at Battle Hospital has been amazing in training several nurses and colleagues in what to do with women who have an abnormal pap smear and making sure they're managed in the right way. And some doctors have been doing hysterectomy have told me that they did it because they didn't know there was another way. So I feel that apart from promoting the screening, we need to also promote what they do when they have an abnormal. Sorry.
Definitely. Dr. Jacqueline, thank you.
Jennifer, so the other thing I also want to say now is women now are very empowered. We're professional women, a lot of women are educated, and because of the internet, the information is available. So it's not simply always just relying on the doctor to, I suppose, spoon feed you that information. Read around, find out about what's available. So you get your positive pregnancy test. You can find information about pregnancy, even from the WHO websites. And then you know what sorts of things, what is the sort of standard, what should I be expecting? I should be having a scan at least to confirm how far pregnant I am. I should be having a scan to check the development of the baby, which is the fetal medical side, check that the heart is developed properly, check that the kidney is developed properly. If I have a mother that had preeclampsia, a sister that had preeclampsia, I may be on taking medications myself for blood pressure, then you know what, you may be at high risk of preeclampsia. Talk to your doctor about it, see whether or not there's anything that can be done. So take back some of the power in your own hands. So I think women should be encouraged to do this because, yes, if the screening procedures are available. So for example, in the UK, every woman is screened at 12 weeks of preeclampsia, fetal growth restriction. And if there is high risk, she'll be given aspirin. A woman will be screened for preterm birth to see whether or not there's a chance her baby can come early. And if she's at high risk, she'll be given medication to try to prevent it, or cervical length scans to check how long the womb is, just in case it opens early. So if these things are not available, then you have to sort of be empowered, find the information and question your doctors more. So I think one of the take-home messages I would really like from this to the women that are listening is that their information is out there and they should seek it. They shouldn't just wait to be told what's happening to them. They should take ownership of themselves, their bodies, because they are actually responsible for themselves and their families.
Okay, excellent. Dr. Bright, thank you.
I think Jacqueline is talking from the perspective of UK. I think that, or I strongly believe that, yes, most women in UK are well empowered. It is not the same in Ghana. One of the things that I observed is the Ghanaian system is very hierarchical. The doctor is up there and the patient is down there. They dare not ask questions, so some can do it, some can inquire, some can probe, but I bet you the majority will not ask questions. Doctor, what do you think? And it even happens in some of these Bengali ladies in this country. They look up to you, the doctor, to guide them, to tell them what. So they do not read, they do not probe, they do not inquire things. What the doctors say is what is right.
Okay? I suppose this is then a cultural difference, and this is something that we must address.
That communication gap is probably a cultural thing. But before you guys talk about screening in early pregnancy, because I think our two fetal medicine consultants can say something about screening, or if there's a national screening in Ghana. We need to work towards empowering our women back home to be more inquisitive about their health, to ask questions. If a doctor says go and have a full blood count, for instance, ask the doctor why.
And I think that's a bigger issue as well. It's not just when it comes to medicine and the kind of care. It can also pan out in the workplace, in cultural settings, because I mean, as somebody based in UK that's kind of moved to Ghana, I also have challenges sometimes engaging with people that are very reluctant to be a bit firm, or reluctant to ask questions in order to get things done, and definitely it's a wider issue. I mean, some people talk about it from the school days and how people are taught in school. Some people talk about it even before in the home. But Ghana, like you mentioned, is very much about the hierarchy, and your elders, you have to respect them. So if the profession or the professional, the doctor in that case, or even the minister or the lawyer, whoever they're coming to see, if they see them as somebody higher than them, they're reluctant to ask questions, even though the questions will be for their own benefit, to get clarification, to get understanding, and ensure, because not without forgetting each of these people, yes, they are trained, yes, they're experienced, but they're also human. Okay, so sometimes you need to question, I wouldn't say question, but sometimes you need to get clarification to ensure that you are understanding what they are saying. And you know, another thing that I tend to get from people as well is that in Ghana, people are reluctant to say no. Everything is yes, I understand, yes. I don't know if that's, you know, what you've seen or you've experienced, but in doing that, it kind of communicates the wrong information. Do you really understand what treatment you need? Do you really understand what's happening with your body? Because there's a reluctance to ask questions, because there's a reluctance to probe, you just assume that the patient understands, and then it becomes a whole different scenario. I guess the question is, how do we overcome that? How do we work towards empowering, like you said, women in general? Because another thing is that, you know, women's, if you want to call it, role in the family, in the home, in the community is also very different. Ghanaians
and the reproduce as well, the pressure to have children, the pressure to reproduce. Perhaps there's a lot of issues around that as well.
And, you know, sometimes, I mean, my background is in education. I used to deal with kids in school in UK who are very vocal, sometimes even too vocal. And, you know, they challenge you on almost everything. And in Ghana, it's slightly different at times. But then how do we work to kind of overcome that so that it's beneficial for all? Because like you said, Dr. Jacqueline, as a female in the home, the pressure is there to have children. If you're not married, or, you know, have children by a certain age, you know, I've heard people being described as abnormal. There's something wrong with you because you haven't done or achieved what society feels you should by a certain age. There's certain women that feel possibly marriage or having children is automation. You understand? It's like, I've achieved once I've got that. So if you're not in that, you know, in that group of people, then you're seen as a bit of an outcast. And again, that leads on to well-being issues with your mental health and how you deal and perceive that, because there are a lot of pressures out there. Just to mention, there's a question that's been put up by Honorin. She says it's interesting that preeclampsia and obstetric, sorry, I can't pronounce it properly, hemorrhage are such a burden on women's health. I'm just wondering if it's something our great grandmothers encountered during pregnancy. Dr. Betty, would you like to answer that, please?
Yes, Jennifer, definitely they were. But, you know, in those days, tracking of the maternal deaths was also a problem. And we've been able to reduce maternal deaths from 800 and something to 310. So that should tell you that previously there were a lot more deaths occurring, and most likely from these two conditions that we still see. So I'll say yes, they were experiencing them, but we were probably not tracking them or taking a record of such deaths.
Yeah. Okay. So again, it's about knowledge, it's about monitoring, and it's about understanding what your body's going through, what your body is saying. We have a question from, she sent a message in. Sorry, go ahead, Dr. Bright.
A few years back in the UK, they embarked on looking into why mothers die. So every 3 years, they come up with a report, okay? Before I went to Ghana in 2018, I was trying to find out whether there is any such collaborative work in Ghana where you can actually go there and see what are the causes of maternal death, what are they doing about it. I couldn't find any. But you will see so many autopsy reports, so many anecdotal reports and studies. You realize that all these conditions, things that kill women in this country, they are literally just about the same, maybe apart from malaria. They're just about the same in Ghana. So this has been going on for years and years and years and years. Probably it's time now that we take hold of looking into why our mothers die and do something about it.
So actually, I know there's a lot of work being done in on that aspect, but as to whether it's being published for public consumption is what I can't really tell. It's true, when you went to the internet, some data goes far back as 2014, 2015. For you to get the current updates on some of these conditions is quite difficult. So yeah, you are right. We need to step up on the work they are doing. They need to probably publish it, make it more public, and it also helps with the advocacy and the education aspect.
If we have a centralized system of collecting this data, it will be very, very helpful. It will be very helpful.
I have a quick question.
Can we screen for the screening early pregnancy? Because I think some people are waiting for some answers from our medicine consultants.
Sorry, what was that, Bright?
Screening, early pregnancy screening, obstetric screening.
Yeah.
So much can be done in pregnancy, between 8 and 12 weeks. In fact, majority, 80% of problems are prevented during that time. So they don't have an opportunity of manifesting. You know, women will have bloods done to check for sickle, to check their full blood count, their iron counts, infection screens. You can have urine swabs. So much can be done and treated so that, number one, it doesn't affect the mother and it doesn't affect the baby. Preeclampsia, which is blood pressure problems in pregnancy, passage of protein in the urine, it can cause strokes in women. It can cause fits in women, and babies can be growth restricted and babies can die. So imagine that you can assess for the risk of preeclampsia at 12 weeks. You can give a woman aspirin and you can reduce that complication happening to that woman later in the pregnancy. And having a complication doesn't just mean that you mother has a complication. The baby may be born early, and then you have to deal with a neonatal baby, a baby that's born before 37 weeks that may have to spend time on the neonatal unit, which is costly. So there can be so much that can be done at the beginning that will prevent the problems later on. So it's really important that the Ministry of Health or whoever the governing bodies are engage in some of these research advances and manifest them, because they will really change the system. I think for me, that is one of the things that if I have an opportunity of coming to Ghana, I would really, really love to work on this type of thing.
Yeah, definitely. Thank you.
I did have a quick question, which is as a diasporan. So as a diasporan coming, how do you engage in healthcare? How would I go about finding a doctor, somebody to give me advice, you know, if I needed to see somebody? What is the process?
And that's the thing. What information is out there? Because from our perspective of those that do come to Ghana and seek our advice and our support, we literally use personal recommendations or recommendations of organizations or individuals that we have worked with or associated with and know how they how they do their work, how they go about doing things, because we want to make sure that we're recommending you to an organization, a clinic, a health center that we know have good standards and have accredited standards as well. So it's very, very important that we look at where information can be collated for people that would like to engage and connect. There's a question on the screen.
People can upload reviews.
Yep, reviews also. Yeah, reviews also.
I don't know whether they do it through your organization. Reviews on whether it's doctors, whether it's lawyers, when they're coming back, if they want to tap in. I don't know if that's something your organization does. Yeah, we do. So we've got a question from Shina Henderson. She's reached out to us and asked if the panel can speak on early womb awareness or wellness screening at the onset
onset of menses, including scans, to girls either 13 to 16 or upon the first period. She says she's aware of many who have reproductive implications much earlier, heavy extended periods, heavy cramps or anemia that are often dismissed until they become complications or infertility. This particular lady had fibroids and precursors that made her fear and avoid pregnancy, yet were not diagnosed till 38. Could this have been reversed?
The answer to this question can take 2-3 days. When you're a girl, the expectation is that you will have your menses. Even these days, girls have their menses around the age of 9, maybe 10.
Yeah.
If by 14, 15, 16, you've not had your menses, then something is not quite right. Okay, so again, this is part of the education that needs to go out there. It could be due to several reasons. You know, it could be a genetic abnormality, it could be a developmental abnormality, but the expectation is that every girl at some stage, 9, 10 years onwards, will have a period and will also develop the normal female sexual characteristics. If by 15, 16, you've not had your period, you really need to seek help from your doctor. All you can't scan all the girls looking for abnormality. It's not practical.
Possible.
Okay, there should be a reason. There should be symptoms presented before you can do that. Having heavy periods and cramps, especially in the early stages of your life, it's usually called spasmodic dysmenorrhea. That is not uncommon. Okay, some painkillers, a few tablets, mefenamic acid, tranexamic acid. These things can help. There's medication, there are treatments that are available for that. For anyone to diagnose fibroids, again, it's usually there is an underlying symptom. So you go and see your doctor, your periods have become too heavy, your tummy is getting bigger. Or if by chance you're pregnant, they scan you, they might find fibroids. So fibroids you cannot reverse unless it's taken out. So I think the answer to this question is there's so many facets of this question. But as a young girl or a family with a young girl, 9, 10 years of age, up to about 13, 14, you should expect them to have a period. If not, seek help. Fibroids, we don't know how, the underlying pathology, but it is so common in blacks. It looks like we are just blessed with it, okay? Unfortunately, but it can present in so many ways. Scanning is a way to detect it. And if it's causing problems, then something can be done about it.
So can fibroids be reduced? Sometimes there's that school of thought. If they're not taken out, can they actually be reduced?
Not permanently, no.
You cannot eliminate it completely. But the answer to your question is yes, you can reduce it. There are treatments. In fact, recently there is a very fantastic medication called Ryco that you give 1 tablet every day. It reduces your heavy periods, it shrinks the fibroids. There are other procedures like uterine artery embolization that is done in this country. It can reduce the fibroids. Or even some injections called Zoladex, it can reduce the fibroids, but it is not without side effects. So the answer to your question is yes, the sizes of fibroids can be reduced. The larger ones, it is very difficult to reduce the size. But it gets to a point, if it's so large, then a surgical intervention will be the way forward, especially if you are around the throes of fertility.
Okay.
I think most of the treatments that reduce is they bounce back. If you stop the Zoladex, they come back. So in my understanding, it's usually reducing prior to surgery or some other thing. And I think uterine artery embolization and, as you say, maybe ultrasonic treatments might be right, but it's all about seeing somebody and getting assessed getting the appropriate treatment, so that if you are suitable for uterine artery embolization, as it's known, where they block some of the blood supply to parts of the uterus to help to shrink the fibroid, then that's the case. But not all fibroids are suitable for that. But if I could just touch on what you mentioned about, scanning all young women, as Dr. Bright said, it's just not, I don't think it's advisable. I think young girls will be being overdiagnosed with all sorts of things if they're scanned too early, or being told they have polycystic ovaries, etc., etc. But I think if you do have a young girl who maybe has persistently heavy periods, or has symptoms of tiredness, or lethargy, seeing a doctor to maybe in the first one just have a blood test, full blood count might be all that's needed to make sure that it's not negatively impacting. But I think you're right. Sometimes women, beyond the adolescents, who have very heavy periods for years, and not only in Ghana but in UK, being dismissed. And certainly when I was in the UK, I have people come into the clinic with a hemoglobin of 4, which is perhaps a third of what it should be, and have been for years dismissed by their GP and just sent away with painkillers. So again, it comes down to listening to the patient, listening to their symptoms. How prolonged is the bleeding? Is there bleeding in between the periods, etc., etc.? All the answers are with the patient. This is what I tell my trainees. So if you don't listen to the patient, how can you expect to diagnose anything?
Okay, thank you. There's one thing just to touch on, and that's about stigma, cultural, traditional, whatever you may call it. There's certain stigma, and even myself as a female, I've heard, aunties and some of the elderly people gossiping, if you want to call it, about that. And that's having a C-section rather than a natural birth, and whether or not, the woman is deemed as, having, actually given birth, or, that kind of stigma. What would you say? How would you, again, possibly it goes along with this question. It says, can someone address the high incidence of CS in Ghana, please?
Who's going to start?
Betty.
Maybe I should take it. So yes,
Betty.
the cesarean section rate, yes, I will. The cesarean section rate in Ghana has actually risen over the past few decades. And there are several factors to it. The first of all, I would say that a lot more women are getting empowered. They have their preferences already on the mode of delivery when they come to the hospital. So maternal request is on the ascendancy in Ghana, especially among the educated women. All right. Most of them don't want to come to the labor wards to go through how many hours of pain, and in the end, they might probably end up with the same cesarean section. So they opt for it even before their term. So maternal request is number one. Secondly, we looking at the primary indications for the cesarean sections. Most of it is as a result of poor progress. And we believe that sometimes the labor monitoring also is not optimum. And the use of the pathograph is not widespread. It looks like we are losing that aspect of labor monitoring. So we just keep a woman without any objective timelines, and then one just gets up and says, oh, you've labored for long. Okay, it's fine. Let's go. Maybe you could have actually intervened earlier. Maybe what the person just needed was augmentation. Maybe something just to keep the labor going. But because we miss it during the monitoring, that is, if we are monitoring at all, then it ends up being prolonged and then ending up in cesarean section. So one thing we are hammering on now, and we are not joking about it, is the use of the pathographs. We are bringing it back to the hospitals, to the health centers, to the polyclinics, all levels of healthcare. We want the pathograph to be the main document that the woman in labor should be monitored on. And also those who have had previous cesarean sections. I know a lot of us obstetricians are still a bit, we are not still comfortable about vaginal birth after cesarean section, and more so about augmentation after, during trial of labor for a cesarean scar. So these are some of the factors. If I'm not being allowed to push just because I had a vaginal delivery, though I may qualify for vaginal delivery after cesarean section, then definitely the CS rate will go up. If my labor is stuck at a point, if I've had a previous section, I've gone into labor and I'm stuck at a point because my contractions are not adequate, and I'm in a facility where my obstetrician is not comfortable with augmentation after a cesarean section, then definitely I am going for cesarean section, and that would increase the rate. So when you look at our teaching hospitals, we are having a CS rate of about 50% or close to it. And it's quite frightening. It's quite frightening considering the risk associated with multiple births after cesarean section. Personally, I'll say I'll include myself in this because I also opted for cesarean section. And I am not at all against women who opt for cesarean section at all. But I think a lot of education, a lot of counseling must go in, and then if they decide to take the decision for themselves, informed consent, then I am okay with it. But I think what we need to work on is proper labor monitoring, and then proper guidelines regarding vaginal birth after cesarean section. I think that would help.
I think Betty's made a very good point. Unfortunately, we need systems in place. We need protocol. We need guidance. Okay. Unfortunately, these are lacking. One of the hospitals that we do training, their cesarean section rate is 58%. So half of the women, 5 to 6 out of 10 women, will end up with a cesarean section. Yes, if a mother wants to have a cesarean section and if you've explained everything and that is what they want, that's okay. Now, one of the reasons for high cesarean section rate also, as she said, is the inadequacy of intrapartum fetal monitoring. So one of the things that the Bridge Foundation is doing is actually teaching on intermittent auscultation and then continuous electronic fetal monitoring. And we've been doing this with a couple of the hospitals. The other thing is, a typical example, a woman who has labored, progressed very well, the second stage of labor, has been pushing for an hour, 2 hours. The baby's head is literally just about dead. The mom is exhausted. Okay? What do? They take her, push the baby back, and do a cesarean section.
Cesarean section.
We do not do instrumental vaginal delivery. So
instrumental delivery is like forceps.
Yes, so forceps and
vacuum.
This appears not to be taught even in the medical schools. So there's a big gap there. The senior doctors at some hospitals, they don't do it. So a baby, just sitting there, they will have to push the baby up and then do a cesarean section. So again, we need to go back and train. And that is what we do. So we need more hands to help. Jacqueline, more hands. Come, let's go.
You know, that's very true. I was actually surprised when I was looking at the stats of one of our biggest teaching, or let me not say biggest, one of the big teaching hospitals in Ghana. And I realized the vacuum rate, we don't do much of forceps in Ghana. It's more of vacuum. The vacuum rate was only 1%. Meanwhile,
That's
the
shocking.
CS rate,
That is really shocking.
1%. I mean,
that is really shocking.
Yes. So we need to do training.
The vacuum machines that they have, it's really, really old type. So anytime we're going, we buy some, kiwi, the portable handheld ones. We go with them and then we donate it to the hospitals, train them how to use it, and leave it with them. So we are doing our bits. Betty, we are coming to you.
Yeah.
Hopefully we can all pull resources together.
Yeah. Sure. We'll join you in the training.
We have a particular doctor, actually. She's based in the UK, Ghanaian doctor based in the UK. And there are a few subjects that we don't tend to talk about or we tend to dismiss. And they are very important to women that have experienced this, and very important to our mental health as women. And that is a death of a child or a death of the fetus before the child is born, during childbirth, or even after. And again, that goes along with the taboo subjects of it being, kind of considered as a possible outcast or judged in society. What happened? You did something wrong. It's your fault. All of that and beyond. And is there any advice that you can give to women that have unfortunately experienced that? And what is the science behind that? I mean, of course, we've talked about preeclampsia. I don't know, Dr. Jacqueline, would you like to delve into that?
Yes, I mean, pregnancy loss is very difficult. It's difficult for the whole family. It's difficult for the woman. It's also difficult for the man. A lot of men go through a lot of difficulties and pain because they also feel it in the same way. The early pregnancy losses, whether that is a miscarriage or an ectopic pregnancy, because an ectopic pregnancy is also an early pregnancy loss. Many times they are unexplained. Currently about 1 in 4 women will lose a pregnancy at the beginning. There may be problems with the way the baby has developed. There may be some genetic factors. There may be chromosomal problems there. The later ones can be because of coming too early. So you can have late miscarriages at, let's say, 18 to 20 weeks. So that's about 4 to 5 months, because the cervix is just opens up. So the cervix, which is the neck of the womb that holds the pregnancy together, just opens up on its own. Sometimes infections can make it open up. And then you get the later ones where the pregnancy was going on, everything was fine. And then all of a sudden, the lady stops feeling the baby move. She goes into the hospital and there's no heartbeat. There can also be pregnancy losses where there's a problem, like the baby's very, very small. It's not growing very well. The placenta's not looking after it well. And then you can have a stillbirth. And then after birth, you can also have neonatal death. So the baby is born, but then there may be some problems and it's not able to take care of itself and doesn't survive. It's very, very difficult. Women often ask questions why. There can be a tendency to blame themselves. What did they do? Was it what they ate? Was it this? But a lot of the times it's unexplained. I think socially, culturally, there can be difficulties because of the expectation of producing children.
Yeah.
And in certain cultures, maybe not necessarily the Ghanaian culture, but in certain cultures in the UK, it can be really, really difficult in the families. The women are not necessarily treated well by the extended family. And especially where it happens over and over again, sometimes in the early pregnancy losses with the recurrent miscarriages. So this is where a woman will have 3 consecutive miscarriages. Then it's like, you know, will it ever happen? Mental health will struggle, but there needs to be a good support network provided. And usually that is the primary healthcare provider and then the family. But then there should also be investigations to look for potential causes. And then if there are any that treated, and also for people to also know that actually it may be that trying for a natural way may not work, but it may be that you may have to look at something like IVF. So there's so many things that come into this. It's actually quite a big topic, pregnancy loss. But I suppose what you're asking is about the cultural pressures that go along with it and the mental health challenges that go along with this. Yes, they can be quite enormous. But I think what we must remember is that we must be there to support our mums, our women, and also our dads.
Yeah. Thank you. I think that's it's such an important topic that people don't often like to talk about because they feel that they bring up, saddened emotions. But it's an important topic to understand. And to receive the support to cope through it. And I think it's very much about the community, the support mechanisms in place, and
not blaming.
The judgmental. There's a question, and I don't even know how to ask this, but I'm going to ask it. Our grandmothers, our great grandmothers, our mothers, we've all been through this, and we've kind of been taught to do this with our children. The carrying of our children on our back, when mothers strap the little baby and child to your back. Some people have raised questions about the child, bowed legs and how it impacts, and also, just generally with the woman's health. I mean, I don't even know if that's a question or how do I even, bring that up, but is it something to be wary of? It's something that you see everywhere in Africa.
It's a good business.
Does it cause issues?
We should not steer away from that culture of sex. It encourages bonding. It does not cause bow leg. It does not. There's no evidence. Okay? Ghanaian mothers have, very lovely backside. The babies can sit there comfortably. Okay?
Mr. Gyampoh, what do you say?
We should not start learning from the European way where they put the babies in front of them. Okay? It is very good. One of the things that it really helps is bonding, and we need to maintain that. We should not go away from that culture. Keep it up. It is far better. The other culture that is being hammered very well in Ghana is breastfeeding. I love the way they do breastfeeding. Absolutely brilliant, and I love them for that because they breastfeed exclusively. All right, and it helps the kids. Keep your babies on the back. When we were in medical school, one of our professors taught us that when you keep the baby girls on their back, it opens their pelvis. Anyway.
I hear you. I mean, it's one of these scenarios where we look at traditions, we look at what's been done in the past, and we look at the science, and we look at the knowledge that we're now acquiring, and whether or not those practices are still some of the best practices, or we need to kind of review them and look at doing things slightly differently. But I mean, what I do want to say, time is fast spent. What I do want to say is a big thank you to all of you. I've learned a lot. It's been a great conversation, a much needed conversation. I believe that there's a lot more that we can talk about and delve into, but because of time, we're going to kind of wrap it up. But before we do go, I think it's important, I call it golden nuggets, for possibly each of you to just share maybe 5 things that people can take away from this conversation, people can share, that you can share with people, with the viewers? And I believe it's not just women. There's a lot of men that are viewing as well, sending questions, comments, and so forth. Things that we need to take away. I mean, because our culture, our ethnicity, our traditions do have a big impact on women's health and how we go about doing things. So anyone like to start off with the 5 golden nuggets, please?
I mean, I'd like to start off with one just for the professional body, to help us to come back, because many of us want to come back and come back home to our countries to do things, to work, to network, to develop services. And it'd be really great for an opportunity to do that.
Yeah, definitely. Thank you.
I think one of the take-home messages or something that I'll put out there is we should, as women in Ghana, we should seek knowledge. We should read, endeavor to improve. Okay, we should also be inquisitive when we go to hospitals and see our doctors. Please ask questions, probe. Don't just take anything that is being given to you. Do not do that, because it will not help you understand how your body and your system works. A message to my colleagues who work in Ghana. One of the things I still do not understand, and I always say, we seem to be somehow stuck in our old ways and doing our own thing. Yeah? Is there any reason why, Betty and Theodora, why we work from 9 o'clock in the morning and finish at 2 o'clock? Why can we not utilize our resources to the fullest, such that you go to a typical antenatal clinic in the morning, you've got about 1,000 women sitting there, because the doctor had to work from 9 to 2. Why can't we do some clinics in the afternoon, clinics in the morning, theaters in the morning, theaters in the afternoon? Please offer our women more avenues, more opportunities. And the second thing is, please look into bringing back community midwifery care, please. And also educating, training, educate them on cervical screening, breast screening. Next time when we come to the men, bowel cancer screening, please. This is my message for the evening.
Yeah, thank you, Dr. Bright. I think that's important. Anyone else, Dr. Betty?
Yes, so I'll take it from where he ended. Actually, that's why we need all hands on deck, and that's why we need you guys to come help, because the truth is that the doctors, the hospitals in Ghana, most of them are understaffed. The doctors overwork most of the time. So if we are going to have clinics throughout the day, then it's a big toll on the doctors, yes, and even the midwives we work with. So we need all hands on deck. Once you come around, I'm sure the numbers will beef up and we'll be able to do exactly as you are saying. One other thing I want us to...
Much doctors. Let's encourage our midwives to do practice.
Sorry, Dr. Bright, we can't hear you properly.
Actually, they do.
The care is too heavily doctor-centered. Okay? Let's get our midwives to do some work, do clinics, to go into the community and do. It will reduce the number of patients that come to clinic.
So it's actually happening. It's actually happening. This I'm talking about happens mostly in the big hospitals, but in the lower facilities, it is actually the midwives who handle antenatal. So that is on course as well. I would also want to talk about male involvement in the journey of pregnancy. Culturally, we know that the men have an upper hand when it comes to decision making in our homes. So if a man is not thoroughly educated about pregnancy and some of the complications that can arise, it can have ripple effects on the mothers and the children as a whole. So we need to get them involved. However we can, they must get involved. We need to educate them. What we've adopted in most hospitals in Ghana is a pregnancy school, where the pregnant women come with their spouses or family members. They come listen to the various topics on pregnancy and women's health. So if we can encourage it in other hospitals, other clinics, other health centers, that also will help to get the men involved. And our community health nurses should also push to get this education to the men in the communities. They live with them, so they have access to them all the time, through their assemblymen, through their chiefs, through their significant people in the society. Once the males get involved, I am confident that a lot of these complications that we see late in pregnancy will be averted.
Thank you, Betty.
Well, I think, Betty, following on from what you said, such a great initiative like this pregnancy school, why isn't it mandatory? Why isn't every facility government mandated to run this? I mean, back in the late 90s, when I came to Ghana briefly, I was one of the first to introduce handheld notes for the obstetric women. And the women said, oh, but if we have our notes, we can go and see anybody. We don't have to come back and see you. And I said, you come and see me because you want to, not because I'm holding you ransom. But even now, there are still clinics that do not give women their notes. I'm pleased to say nationally, you know, the NHS hospitals, they do have their booklet, which they move around with. But, you know, so I'm saying things can change. And this pregnancy school is a great initiative. And my colleague, Dr. Bright, when he said the women should ask questions, well, we need to speak to our own professionals, doctors and nurses, to be ready to receive those questions, because there's no point encouraging women to ask the questions if they keep being shut down. And I keep telling women, it's about informed consent. Even if I'm going to do a blood test on you, just a full blood count to look for anemia, I should explain to you why I'm doing that. You know, and I should give you a copy of your result, especially when they're paying for it. They should have a, sometimes people come say the clinic wouldn't give me a copy, and then we have a fight about it. Well, I have a fight with the clinic, they won't release the copy. But you know, it's that thing of there's a lot that we have to do as healthcare professionals. And in terms of, you know, midwives doing more antenatal care, same thing in cervical screening. In the UK, you know, we will do colposcopy on, you know, a few hundred women in a week, but the majority of that is done by trained nurse colposcopists, because the doctors alone, we're doing other things. We simply couldn't cope with the burden of the number of things that need to be done. So if you have the midwives helping and the nurses helping, then maybe you can work 9 to 2, but I still don't agree with that anyway. I mean, I came to do some training at a hospital in Ghana a few years ago, and they wanted to close at 2 o'clock. And I'd taken time off from my UK practice to come to Ghana, and they wanted to work 9 to 2. I said, why is that? They said, nobody is paying them after 2. I said, you're in training, for God's sake. And I threatened to pack up and go back. And then we started doing, they didn't go home till 7 o'clock in the evening by the time I finished. Because, you know, it's about investing in yourself. So, but my main take-home message is, doctors, nurses, be compassionate to people who are sick. Please listen to them, invite questions, and the whole experience will be much better for you, much better for the patient. You will learn more about what's wrong with your patient, and everybody will be happier. And just one last thing, I have had some women having C-sections. I'm not saying you, Dr. Betty, but having C-sections because they think it keeps the vagina tight. It's not true. The mere thing of carrying the pregnancy, you know, your pelvic floor muscle are suspending this baby for 9 months. That's going to kind of mess with your pelvic floor. So, you know, like places in
Thank you for
Brazil have
being real.
65%. Pardon?
Thank you for being real about those stigmas.
Well,
Thank you.
it's true. So I'm just saying, in case there are women out there who think it's because of, you know, they can keep the vagina tight by having C-sections, it's just not true. I think certainly in our situation where if you know that 60% of women are going to end up with a C-section, then of course women might be thinking, well, I might as well just get my C-section done and get it done with. So it's a chicken and egg thing, because we're not doing active management of labor, because we're not doing any instrumental deliveries. That then feeds the idea that actually you're likely to end up with a C-section, and then it spirals on from there. Somewhere we've got to break that cycle and show people that we actually can deliver you normally. Anyway, I'll stop talking now.
Thank you all so much. Dr. Jacqueline, any final words before I kind of wrap up? And then
I think we've covered everything. I think our last points, you know, about listening to patients, I think that's so important, and also the patients, you know, being more empowered to ask more. So thank you so much, everyone. It's been wonderful to get together today. Thank you.
Thank you all so much. I just want to quickly say a word from our GUBA Foundation manager. So under the GUBA enterprise, we have several different projects and several different initiatives, and one of them is the GUBA Diaspora Network, which supports those in a diasporan community that want to engage, connect, do business and invest in Ghana. But we also do have a GUBA Foundation, which is our charitable arm of the GUBA enterprise, and we run various projects, various campaigns to support people in our community, whether it be autism, you know, supporting a family, those that have been affected by autism, through various workshops, campaigns, conferences, whatever it may be. We've done something on infant mortality, the death rates of children, young babies between the ages of 0 to 1. Is quite high in some instances, and it's all because of a lack of resources and, you know, the correct medical support that women do need. And there's a variety of different areas that we also focus on. So Priya, who's on, is very inspired by today's session. She's very grateful to you, Dr. Jacqueline, Dr. Bright, Dr. Theodora, Dr. Betty, for your time, and thank you ever so much for your passion towards raising awareness in women's health. And it definitely is a much needed open conversation because it covers lots of different aspects. For anyone that would like to reach out to the GUBA Foundation and find out a bit more about what we do, you may be able to contact Priya, Priya at gubafoundation.org. I will also share information about the various doctors that we have on tonight's session. If you do want to find out a bit more about the GUBA Diaspora Network, you can contact us at info@gubadiasporanetwork.com as well. Doctors, thank you, and thank you ever so much.
Amazing. Thank you.
You're welcome, and continue doing.
Thanks for the opportunity.
Thank you so much. Okay, good night, everybody. Good night.
Good night.
Good night. Bye-bye.
Hopefully, the Trowbridge Foundation can do some work with GUBA.
Yes, we will. Good night.
Bye-bye.